Cyanotic congenital heart diseases. Cyanotic congenital heart diseases are rarely seen compared to acyanotic congenital heart disease. Cyanotic congenital heart disease are dependent and divided on the basis of increased pulmonary blood flow and decreased pulmonary blood flow. Increased pulmonary blood flow is seen in hypoplastic left heart syndrome HS, hypoplastic left heart syndrome, truncus arteriosus, transposition of great arteries TGA, total anomalous pulmonary venous connection TAPVC, total anomalous pulmonary venous connection. Decreased pulmonary blood flow is most common. So most common is what? Decreased pulmonary blood flow is cyanotic heart diseases, in which you have your tetralogy of Fallot, which is most common. Tricuspid atresia. You have your tricuspid atresia and abstinence anomaly. Tricuspid atresia and abstinence anomaly. Tetralogy of Fallots. There are 4 components. That's why it's called tetralogy, because there are 4 components. What is the first one? Overriding of aorta. That is shift of aorta towards the right. Pulmonary artery output inversely proportional to severity of subpulmonary stenosis, determinant of cyanosis. Second is right ventricular hypertrophy. So first is overriding of aorta, second is right ventricular hypertrophy, third is ventricular septal defect, and fourth is subpulmonary stenosis, also known as infundibular hypertrophy, right ventricular outflow tract obstruction. What is subpulmonary stenosis? Also known as infundibular hypertrophy or right ventricular outflow tract obstructions. So you have oxygenated blood, deoxygenated blood, and mixed blood. Clinical features: cyanosis, onset within 4 months after birth. Ovaries with severity of subpulmonary stenosis. Cyanosis, onset within 4 months after birth, varies with severity of subpulmonary stenosis. Single S2 heart sound, A2 heard, P2 not heard due to stenosis. So there is a single S2 heart sound. Murmurs, ejection systolic murmur heard in pulmonary area, disappears during cyanotic spell. Surest sign of tetralogy of Fallot. Ejection systolic murmur, which is heard in pulmonary area, disappears during cyanotic spells, is the surest sign of tetralogy of Fallot. So ejection systolic murmur, which is heard in the pulmonary area of the it disappears during cyanotic spell, and that is the surest sign of tetralogy of Fallot. VST is non-destructive, no turbulent flow, no pensystolic murmur, free flow across VST. VST is non-restrictive, no turbulent flow, no pensystolic murmur, free flow across VST. Cyanotic spell, increased severity of cyanosis, disappearance of shunt murmur during cyanotic spell, surest sign of TOF. In cyanotic spell, increased severity of cyanosis, disappearance of shunt murmur during cyanotic spell is the surest sign of TOF. First, worsening of hypoxia, then second is increased lactic acidosis, then third is stimulation of respiratory center in the brain, hyperventilation, increased venous return, INTOF, infundibular spasm, narrowing, cyanosis, increased cyanosis. Management: O2 inhalation, sodium bicarb, morphine to depress respiratory center, beta blockers. Squatting in older children, knee to chest posture in infants. Squatting in older children, knee to chest posture in infants. Sixth is alpha agonist, like phenylephrine. Knee to chest posture Causes femoral artery compression, increase systemic vascular resistance in aorta, increase afterload for heart in the left ventricular, decreased flow from right ventricular to left ventricle, decreased deoxygen blood in the systemic circulation, decreased cyanosis. Alpha agonist that like phenylephrine also increases systemic vascular resistance. X-ray finding, you find boot-shaped heart. Here is your right ventricular hypertrophy, and here is the uplifting of apex. Right ventricular hypertrophy and uplifting of apex. Surgical treatment, definitive, VST repair plus correction of stenosis, performed in less than 3 months. What is the surgical treatment of tetralogy of Fallot? VST corrected and correction of stenosis in less than 3 months. Palliative shunt surgery, improve pulmonary blood flow, improve cyanosis. In delayed presentation, contraindicative to definitive surgery. Shunt surgery to improve pulmonary flow, improve cyanosis. In delayed presentation, contraindicated to definitive surgery. Method, shunting systemic artery to pulmonary artery. Palliative classic Blalock tossing, BT shunt with subclavian artery. BT shunt with subclavian artery, this is the first palliative surgery. Classic Blalock tossing. Second is artificial conduit use, second modified Blalock tossing, most commonly done. Third is Waterstone shunt with ascending aorta. Waterstone shunt with ascending aorta. Fourth is Potts shunt with descending aorta. Waterton shunt with ascending aorta. Potts shunt with descending aorta. Tricuspid atresia, pathophysiology. Atresia of tricuspid wall, decreased blood flow to right ventricle, decreased blood flow to PA, right. Cyanosis, ECG finding in tetralogy of Fallot, left axis deviation is seen. ECG finding, left axis deviation is seen. All congenital heart disease are diagnosed by echocardiography. All congestive heart failure, congenital heart diseases are diagnosed by echocardiography. Shunt surgery. Multiple shunt surgeries are performed in stages. Modified BT shunt is done immediately, followed by second is Glenn shunt, followed by third is Fontaine shunt. So superior vena cava connected to pulmonary artery. In the diagram A, absence anomaly, pathophysiology. In absence anomaly, there is increase in right atrium size, atrialization of right ventricle, normal position of tricuspid wall, size of right ventricle reduced right ventricular blood volume, reduced blood flow to PA, and that's why cyanosis. Box shaped heart of Epstein's anomaly. Association, lithium exposure, accessory pathway on right side of the heart, full Parkinson-White syndrome, abnormal electrical communication between right atrium and right ventricular bundle of Kent, early pre-excitation of right ventricle, slurring of QRS complex. Treatment: cone repair of tricuspid wall, return wall to original position. ECG changes are shown here. Hypoplastic left heart syndrome, pathophysiology: atresia of mitral wall, no communication between left atrium and left ventricle. Second is hypoplastic left ventricle. Third is hypoplastic aorta, severely decreased systemic flow, shock in neonates. AST, seen in majority of cases, increased blood flow to right atrium and right ventricle. Early onset congestive cardiac failure in less than 1 week. Early onset congestive cardiac failure in less than 1 week. Treatment: fatal if untreated, at delayed treatment. Hypoplastic left heart syndrome is fatal if untreated or delayed treatment. Norwood procedure, surgical creation of new aorta to increase blood flow. Truncus arteriosus, common outflow tract mixing of oxygenated and deoxygenated blood and hence causes cyanosis. Type of conotruncal defect includes TOF, tetralogy of Fallot, interrupted aortic arch, etc. Associated with Digeorge syndrome, truncus arteriosus. Treatment: Rastelli's procedure, truncus arteriosus, patient normal blood outflow. Position of great arteries, physiology, transposition of great arteries with intact interventricular septum. So parallel circulation, two separate blood flow tracks for oxygenated and deoxygenated blood flow. Early onset cyanosis within few minutes, fatal. Transposition of great arteries with ventricular septal defect. Blood flows from left ventricular to right ventricular, mixing of some oxygenated blood and deoxygenated blood, presents with less intense cyanosis plus pensystolic murmur plus congestive cardiac failure due to majority blood flow through parallel pathways. X-ray findings: string due to narrow positioning of great arteries. Egg heart, egg-shaped heart, egg on string appearance. Egg on string appearance of the heart. Treatment: transposition of great arteries with intact ventricular septum. Emergency condition: PGE1 infusion immediately at birth. PGE1 infusion immediately at birth keeps ductus arteriosus open, oxygenated blood from PA to aorta. Atrial septotomy, surgical connection between right atrium and left atrium made, increase O2 status. TGA with VSD, electively few weeks after birth. Definitive treatment: Jatins aerial at arterial switch repair. Total anomalous pulmonary venous connections, pathophysiology, abnormal connection between PV and RA. Types based on route of blood flow. Most common is supracardiac. Second is cardiac and third is infracardiac. Presentation: obstructive type, pulmonary venous obstruction, congestion of lungs, severe cyanosis. Non-obstructive type, most common, equal O2 saturation in all heart chambers, atrial septal defect, wide fixed splitting of ST, mixed blood in aorta, cyanosis, increased blood flow, congestive cardiac failure. X-ray findings: supracardiac TAPVC, snowman appearance, figure of 8 appearance due to increased SVC size. that is total anomalous pulmonary venous connections. Snowman appearance, figure of 8 appearance is seen in supracardiac total anomalous pulmonary venous connection. In the next video, we'll see acute rheumatic fever.